Imagine an architectural blueprint where, the walls and the roof are perfectly drawn, but the entire foundation is just, well, completely missing.
Right, like they forgot the most crucial part.
Exactly. And in embryonic limb development, that is what we call an intersegmental arrest. The hand forms, but the arm connecting it to the shoulder uh, just doesn't exist. Today, we are doing a massive, comprehensive deep dive into the Swanson classification of congenital limb deformities.
Yeah, and if you are listening to this right now, you're likely staring down the barrel of your board exams.
Oh, 100%. You're probably prepping for the FRCS and plastic surgery, and you just need high-yield facts, fast. So that is exactly what this is, a rapid-fire, high-yield revision session designed specifically for you.
It's a rigid historical system, and it catches a lot of residents out on multiple choice questions. We're going to completely deconstruct it today and get straight to the facts.
But hey, before we start this Q&A, hit the follow button right now so you can hear more of these targeted revision sessions. And, rate the show if you find this breakdown useful.
Also, if you want to take your prep to the absolute next level, make sure to get a premium subscription.
Right. The premium subscription is how you access our journal club and clinical cases episodes. You definitely want that. Okay, so let's unpack this comprehensive breakdown of Swanson's classification. To start us off, let's look at the very earliest stages of embryonic limb development.
This is basically where the process either fails completely or the parts form, but they just, well, fail to separate.
Yeah, so think of category I as missing the architectural blueprints entirely. The biological 3D printer just stopped working. Whereas category 2 is when the parts are there on the building site, but somebody spilled super glue everywhere.
I love that analogy.
Okay.
The parts formed, but they got glued together.
Right. So let's break down category I for us. Failure of formation of parts, which is also heavily referred to as an arrest of development. What exactly are we looking at here?
Well, in category I, the failure of formation, you're dealing with a scenario where embryonic development simply stops in its tracks. You need to have two main subtypes locked in your memory for the exam.
And those are transverse and longitudinal, right?
Exactly. Transverse arrest and longitudinal arrest. Let's look at transverse arrest first. You can think of this as a clean anatomical cutoff point.
Like a guillotine effect.
Yeah, guillotine effect. Embryologically speaking, development just stops at a certain level and absolutely nothing forms beyond it.
Okay, so a little horizontal line across the blueprint where nothing gets built distal to that line.
Precisely. And for your exams, you need to be able to explicitly list these specific levels of transverse arrest, moving from proximal to distal. You have to know all 8.
All 8, okay. Lay them on me.
They are the shoulder, the arm, the elbow, the forearm, the wrist, the carpal, the metacarpal, and finally the phalanx.
Let me repeat those to lock them in, because if I'm sitting in the exam hall, visualizing walking down the arm, I want to make sure I don't skip a joint.
That's a good strategy.
So it's shoulder, arm, elbow, forearm, wrist, carpal, metacarpal, phalanx. It's essentially every major segment and joint line moving straight down the limb. So what about the second type, the longitudinal arrest?
Well, longitudinal arrest is where the failure of formation runs parallel to the long axis of the limb, rather than straight across it.
Got it. Along the axis.
Right. And again, you need to explicitly know the 4 types listed here. First, there's the radial ray arrest. Second, the ulnar ray arrest. Third, the central ray arrest. And actually, I want you to heavily underline this third one in your notes.
Wait, why? What is the specific exam trap with central ray arrest?
Because central ray arrest is commonly known as cleft hand.
Oh, of course.
Examiners love to use that older clinical term, cleft hand, in the stem of a question and then ask you to categorize it.
Sneaky. So you need to immediately map cleft hand to central ray longitudinal arrest, which puts it squarely in category 1.
Exactly. And finally, the 4th type is the intersegmental type, which is also very frequently referred to as the intercalated type of longitudinal arrest.
Ah, this is the one I mentioned in the intro, right? Where the intermediate parts are missing, but the distal parts are present.
Yes, exactly.
Like focomelia, where the hand might be attached almost directly to the shoulder.
Precisely. The proximal and distal elements might be there, but the intercalated segment, the middle part, fails to form. That is longitudinal arrest.
Okay, so to recap category R really quick, transverse is the clean horizontal cut, and longitudinal is along the axis, which gives us radial ray, ulnar ray, central ray, which is cleft hand, and the intersegmental or intercalated type.
Spot on.
So let's shift our focus to category 2. This is the superglue scenario you were talking about earlier, the failure of differentiation or the failure of separation of parts.
Right.
For the boards, how do we categorize this? Because we're dealing with different types of tissues that could be stuck together.
Category 2 is heavily tested specifically because it forces you to distinguish between what structures are actually failing to separate.
Ah,
It's subdivided into 3 distinct groups: A, B, and C. Group A is soft tissue involvement, Group B is skeletal involvement, and Group C covers congenital tumorous conditions.
got it. Let's detail the soft tissue involvement first, the group A conditions. So the bones themselves are totally fine, but the soft tissues are glued together.
Exactly.
What exactly falls under the soft tissue failure of differentiation?
There are 4 key presentations to list here. First is arthrogryposis. Second is cutaneous syndactyly. And it is absolutely vital to specify cutaneous here.
Because that implies purely a soft tissue web between the digits, right?
Exactly. Third is camptodactyly, and fourth is thumb and palm deformity. All 4 of these represent a failure of soft tissue parts to properly differentiate and separate during early development.
Wait, before we move on, let's make sure we have a really clear visual for the exam on those last 2, because the jargon can definitely blur together when you're stressed out.
Oh, for sure. It happens in the time.
So camptodactyly versus clinodactyly. Camptodactyly, which you just put in the soft tissue group, that is a flexion deformity, right? Where the finger is bent forward toward the palm, usually due to soft tissue contractures.
Correct. Camptodactyly is typically a flexion deformity at the proximal interphalangeal joint driven by soft tissue issues.
Yeah.
That is exactly why it sits in group A.
Okay, got it. Arthrogryposis, cutaneous syndactyly, camptodactyly, and thumb in palm deformity. All soft tissue, all category 2. What about group B, the skeletal involvement?
So group B is where the actual bones themselves fail to separate. And again, you are looking at 4 specific items. First is clinodactyly.
And to contrast that with what we just discussed, clinodactyly is when the finger curves sideways in the radial ulnar plane, right? Like
Yeah.
the pinky bending toward the ring finger, which is a skeletal issue with the bone shape itself.
Exactly. It's a skeletal deviation, so it's in group B. Second in this group is osseous syndactyly.
Yeah.
And notice the strict distinction there.
Yeah, between cutaneous and osseous.
Right. If the multiple choice question describes cutaneous syndactyly, you're dealing with soft tissue involvement. If it's osseous syndactyly, the bones themselves are fused, making it skeletal involvement.
That is a classic board trap. They'll give you a clinical picture of webbed fingers and ask for the subclassification. You have to know if it's cutaneous or osseous to get the point.
You really do. The third presentation in Group B is symphalangia, where the phalangeal joints fail to differentiate, so you get a stiff, unjointed finger.
Unjointed finger, okay.
And fourth is synostosis, which is a broader fusion of bones. For the FRCS, you must specifically remember that this syntosis can occur at the elbow, the forearm, and the carpal levels.
That is a crucial distinction. Cutaneous syndactyly is soft tissue, osseous syndactyly is skeletal, and then synostosis specifically of the elbow, forearm, and carpal. You mentioned a third subdivision as well for category 2.
Yes, subdivision IC is simply classified as congenital tumorous conditions.
Yeah.
It just sits under failure of differentiation, rounding out category 2.
Okay, so we've covered category missing the blueprints and category 2 parts failing to separate. Now the anatomy shifts away from missing or fused structures, and we move into anomalies of excess and proportion.
Right, we're looking at the extremes now.
Exactly. Either there are too many parts, or the parts that are there are improperly sized. Let's walk through categories 3, 4, and V, which deal with duplication and severe size discrepancies. Let's start with category 3, duplication.
Well, category 3 is all about duplication, meaning extra parts. You need to break this down by the presentation of the duplication.
Okay, how so?
It can involve the whole limb. It can involve specific long bones, so you might see duplication of the humerus, the radius, or the ulna. Then you have mirror hand, which is a very distinct, severe duplication deformity.
My mind immediately goes to extra digits when I hear duplication. How does the Swanson classification handle polydactyly?
It breaks extra digits down by anatomical position.
Yeah.
And you really must know the alternate terminology here, because the exam will test both.
Okay, lay them out for us.
First, there is radial polydactyly, which is also heavily referred to as preaxial polydactyly. Second, there is central polydactyly. And third, ulnar polydactyly, which is also termed postaxial polydactyly.
Let's anchor that so the listener doesn't mix them up. If we think about standard anatomical position palms facing forward, the thumb is on the outside, the radial side. That is the preaxis. So radial is preaxial.
Perfect way to remember it.
And then the pinky is on the inside, the ulnar side. That is the postaxis. So ulnar is postaxial, radial is preaxial, ulnar is postaxial.
That's the exact logic you need. Radial equals preaxial, ulnar equals postaxial. And all of those fall firmly under category 3, duplication.
Excellent. Let's move to category 4, Overgrowth, when the parts are there, but they are just way too big.
Category fourth is relatively straightforward, thankfully. Overgrowth is isolated to just two presentations in this classification.
Just two.
Yep. It's either an overgrowth of the whole limb or it is macrodactyly, which is the overgrowth of the digits. That is the entirety of category 4.
Nice and simple. Whole limb, or macrodactyly. Which brings us to the complete opposite end of the size spectrum, category V, undergrowth. This one feels like a minefield of highly testable specifics.
Oh, it absolutely is a minefield. Category V covers undergrowth, and you need to be extremely precise here. It includes undergrowth of the whole limb, as well as undergrowth of the whole hand.
Okay, and what about specific bones?
Then we get into specific bones and digits. It includes brachymetacarpia, which translates to short metacarpals. It includes brachydactyly, which is short digits. But the absolute most critical one to remember for category V is brachysyndactyly.
Brachysyndactyly, short webbed digits. Why is this specific condition so critical to highlight for the undergrowth category?
Because the classification explicitly notes a crucial variation in its presentation that examiners absolutely love to test.
Okay, ready.
In category V, brachysyndactyly can present with or without the absence of the pectoral muscle. The fact that the pectoral muscle absence is specifically tied to this undergrowth category is a detail that shows up constantly on board exams.
Man, that is exactly the kind of nuance that separates a passing score from a failing one.
Oh yeah, without a doubt.
So when you see brachysyndactyly, you have to immediately think category V, and you have to remember it can present with or without the pectoral muscle absence.
Correct.
So we've covered isolated anatomical formations in categories 1 and 2. We've covered duplications and sizing in 3, 4, and V. Now, the classification turns to deformities that are caused by external intrauterine forces or, generalized systemic issues.
Right, we're zooming out a bit here.
Exactly. So how do constriction bands and chromosomal issues fit into the Swanson framework? Let's look at category 6 first.
Category 6 is congenital constriction band syndrome. This is a big shift because now environmental factors in the womb come into play.
Like amniotic bands wrapping around the developing limb.
Exactly. The classification details 3 specific presentations under this syndrome. First, the constriction band can present either with or without lymphedema.
Because the band is physically choking off the lymphatic drainage of the developing limb.
Exactly. Second is acrosyndactyly. This is where the digits are fused distally due to the bands clamping down on them during development.
Oh, wow. Okay, it's in the third.
And third is intrauterine amputation, where the band is so tight it essentially amputates a part of the limb before the baby is even born.
Okay, so constriction band, with or without lymphedema, acrosyndactyly, and intrauterine amputation, all firmly in category 6. And I guess that leaves us with the final category, category 7.
Right. Category 7 is generalized skeletal abnormalities. This is sort of the catch-all category for systemic issues that affect the skeletal system as a whole.
Rather than just an isolated event in the limb bud.
Yeah, precisely. It specifically encompasses chromosomal abnormalities, as well as a group simply termed other generalized abnormalities.
Okay, we have successfully laid out the entire blueprint of the classification, from category 1 to category 7. We've talked about the missing blueprints, the glued parts, the extra parts, the oversized and undersized parts, the bands, and the systemic issues.
We covered a lot of ground.
We really did.
Yeah.
But here's where it gets really interesting. And if you are listening to this right now, this is where your higher order critical thinking needs to kick in for the clinical viva portion of the board.
Oh, definitely. This is the stuff examiners love to push you on.
Right. This Swanson classification is widely accepted. It's the gold standard for exams. But, it's based on work published way back in the 1960s and 1970s.
Yeah, it's old.
Since our modern understanding of embryology and pathogenesis has progressed significantly since then, the shortcomings of this classification have become totally glaring. Where does this 60-year-old classification actually fail us in clinical practice?
Well, the major diagnostic difficulty, and this is a highly debated topic that residents absolutely need to understand, is differentiating between 3 specific conditions.
Which are?
Transverse arrest, brachysyndactyly, and symbricodactyly. Now, a quick note on symbricodactyly for your exam prep. This was previously termed atypical cleft hand.
Okay, so be acutely aware of that older terminology.
Yes. The difficulty arises because our modern understanding of these conditions simply doesn't perfectly fit Swanson's rigid categories.
Let's unpack this logical inconsistency because this is exactly the kind of conceptual debate an examiner will, push you on. Let's look at the logic here.
Okay, let's do it.
Some modern experts consider brachysyndactyly and symbrachydactyly to essentially be the exact same entity, existing on a continuum with transverse arrest.
Right.
But hold on. We established right at the beginning that transverse arrest is a failure of formation. It's a category I defect. So if brachysyndactyly is on a continuum with a category I defect, why on earth did Swanson stick brachysyndactyly all the way down in category V, which is undergrowth? I mean, it feels like a massive contradiction.
It is a contradiction, and this is a fantastic question. It really highlights the tension between the historical justification of the system versus our modern understanding of pathogenesis.
Did Swanson realize this when he was making it?
He did. Swanson himself actually noted this exact problem when he was creating the system. He openly acknowledged that brachysyndactyly could technically be placed in Category 1 as a failure of formation, or even in Category 2 as a failure of differentiation.
Because embryologically, it shares features of both.
Exactly. However, he argued that its most obvious clinical failure, the thing you see most prominently when physically examining the patient in the clinic, is hypoplasia, or undergrowth. Because that physical hypoplasia is the dominant clinical feature, he ultimately made the decision to place it in Category V.
So he essentially just threw his hands up and categorized it based on its most obvious visual presentation rather than its underlying embryological cause.
Basically, yes.
He prioritized what it looks like over how it actually happened. That is a massive compromise for a scientific classification system.
Does the wider surgical community just accept this stalemate?
Well, not without a significant amount of debate. In fact, to illustrate just how deeply this issue runs in the community, you should know about an observation made by Buck Gramco in 1999. Okay, what did Buck Gramco say?
He explicitly wrote that the Congenital Committee of the International Federation of Societies for Surgery of the Hand, the IFSSH, had recognized this exact problem of symbrachydactyly classification as far back as 1995.
Wait, the Global Authority on Hand Surgery recognized the flaw in 1995. So what did the committee decide? How did they fix the classification?
They didn't fix it.
You're kidding.
Nope. Buck Gramco pointed out that despite officially recognizing the problem in 1995, the committee utterly failed to come to any conclusions or recommendations. The dilemma remains entirely unresolved in the official classification to this day.
That is fascinating. The Congenital Committee of the IFSSH recognized the flaw, but just could not come up with a better, universally accepted way to categorize it.
Yeah, it's a 60-year-old system with a known bug that no one knows how to patch.
That really leaves you with a final thought to mull over as you prep for these exams. If the top experts in the world couldn't neatly categorize the continuum of symbrachydactyly and transverse arrest, well, it highlights how rigid classification systems often struggle to capture the fluid, messy reality of embryonic pathogenesis.
Absolutely. Biology doesn't always read the textbook.
Exactly. When a biological process fails, it rarely checks a neat little box. So the question becomes, does forcing a deformity into a flawed historical category actually impact our surgical approach in the operating room? Or is it purely an academic exercise just for passing a board exam?
It's a great question to reflect on.
Think about that as you review your notes today. Understanding the flaws in the system is just as important as memorizing the system itself. And hey, we want to hear from you as well. Go to the show notes and leave a comment or a question about your own experiences memorizing these categories for the boards.
Yeah, what mnemonic works for you? How do you keep cutaneous and osseous syndactyly straight when the pressure is on? Drop it in the comments.
And remember, hit follow right now to catch all our revision sessions and look into that premium subscription specifically for the Journal Club and Clinical Cases episodes to really test your knowledge. Keep studying, trust your preparation, and we will see you on the next deep dive.